Well, good evening, everybody. I'm Neil Mortensen. I'm President of the Royal College of Surgeons of England, and it's a pleasure to introduce you to this webinar, Avoiding a Bleeding Crisis, Tranexamic Acid is Part of the Answer. If I could have the next slide, please. We have some great panelists for you this evening. Professor Ian Roberts is Professor of Epidemiology at the London School of Hygiene and Tropical Medicine, has been especially involved in the tranexamic acid story, as he'll be explaining in a moment. And it's also a great pleasure to introduce Professor Ramani Munasinghe, who is National Clinical Director for Critical and Perioperative Care and a consultant anaesthetist. It's a very timely moment to have this webinar, of course, because we've just come out of an Amber Alert on blood transfusion supplies. And I think it's made everybody think really carefully about how they use blood and how not to use blood. And we'll be discussing all those issues as part of the webinar as we go on this evening. Now, we normally show this slide just to say that I speak on behalf of the College of Surgeons, but my other colleagues can say exactly what they like because they're not part of the college staffing. So without further ado, I'm going to ask Professor Ian Roberts to make his presentation. After that, Ramani will be making some further comments, and then we'll be inviting your questions. So as we go along, please do think of the questions you want to ask, whether you think this should be part of the WHO checklist, whether you have particular concerns about its use, whether you've come across anything that's put you off using it, all of those things. We'd like to hear from you. But first of all, Ian, please, thank you.
Thank you very much, Neil, and thank you for all the attendees for coming to this session. So my name's Ian Roberts. I'm a professor of clinical epidemiology at the London School of Hygiene, and I've been working on tranexamic acid and clinical trials of tranexamic acid for the past 20 years. It seems remarkable. So I'm going to tell you the story of tranexamic acid, literally from its birth to the present day. And I think it's an exciting story, and I'm looking forward to you being part of it. So tranexamic acid started with this little girl. This is Utako Okamoto. This is Japan in 1926. And this little girl wants to be a doctor when she grows up. That was quite unusual at that time because medicine in 1926 in Japan was heavily male dominated, and for a woman to want to be a doctor was quite unusual. But everybody said this kid was super bright. You know, she was a real bright spark. Some people said she was a genius. So she goes to medical school. Here she is doing dissection. She qualifies. She goes in. She immediately gets into research. She's fascinated by hematology and coagulation. Here she is working on a laboratory animal, and she marries another scientist called Shosuke Okamoto, and this is her daughter in the front of the picture. There was no childcare in those days, so she brought her daughter to the lab with her. And this is the family. They were a science family. They were a medical science family. That's the family dog, although you'd be a bit nervous being the family dog in that family. But they were interested in bleeding and coagulation. Now, at that time, so this is an electron micrograph of a fibrin blood clot. And they knew that when this yellow fibrin mesh forms, that there was an enzyme in the blood called plasmin that actually chops up this fibrin mesh and makes the clot unstable and worsens bleeding. And they thought, if we could find a drug that inhibits this enzyme, it might be an effective treatment for postpartum hemorrhage, because Japan in the 1930s and 40s was quite a poor country. And in Japan, women used to deliver their babies and then bleed and die, just as they do in parts of sub-Saharan Africa and South Asia very often today. So they were looking for a treatment for postpartum hemorrhage. And they started off developing an assay, a sort of an assay for this enzyme, and they tested different compounds to see if they could inhibit this enzyme. And they found that lysine, the amino acid lysine, was very inhibitory. So and then they were clever biochemists, and they looked at the structure of lysine, and they made a drug. First, they made a drug called aminocaproic acid, but then they made a better drug called tranexamic acid, which is a lysine analog, which is highly inhibitory of this enzyme plasmin and the thing that it does, which is fibrinolysis, fibrin clot breakdown. So they'd invented a new drug, and they published it in the KO Journal of Medicine in September 1962. And it's the first of those of the papers on the list there. So, you know, relatively obscure medical journal, to say the least. But over the years, people started using it, and surgeons in particular started using tranexamic acid, and particularly cardiac surgeons, because there was very clear evidence that tranexamic acid reduced bleeding and reduced the need for blood transfusion in surgery. There have been hundreds of trials, and there's over 100,000 patients in randomized trials of tranexamic acid in surgery, and without any doubt, it reduces surgical bleeding by about 1/3. So quite a large reduction in surgical bleeding with tranexamic acid. Now, a lot of the trials were small, and you know, you have to be skeptical about small trials, but in recent years, they've been doing larger trials to see if tranexamic acid reduces surgical bleeding. This is a reasonably large trial, nearly, well, 4,500 patients. And the primary outcome here was death or thromboembolic events. So clear evidence that tranexamic acid reduces bleeding, but obviously you're concerned that it might increase the risk of unwanted clotting. And so that's, in this big trial, the Atticus trial, the primary outcome was thromboembolic events, death or thromboembolic events. And as you see, they didn't find any increase in thromboembolic events with tranexamic acid. In fact, they found slightly less, not significantly less, but they found less thromboembolic events with tranexamic acid. They also found that it dramatically, just like all the other trials that have gone before it, they found that tranexamic acid dramatically reduced the need for transfusion in surgery. So almost halved the need for transfusion, and then major hemorrhage or cardiac tamponade leading to reoperation occurred in significantly fewer of the patients in the tranexamic acid group. So very strong evidence that tranexamic acid safely reduces the risk of bleeding in surgery, and no apparent increase in the risk of vascular occlusive events, thrombotic events. So this is when my group at the London School of Hygiene got interested in this, because we work on trauma, and we do large global trials of treatments for trauma. And we thought, well, surgery and trauma are quite similar pathophysiologically. The body doesn't know really if it's being cut open by a scalpel or if it's being cut open by a flick knife. And so there's strong evidence that tranexamic acid reduces surgical bleeding. It should reduce traumatic bleeding. And we launched a very large global trial called the CRASH-2 trial. We randomized 20,000 bleeding trauma patients in 40 countries around the world. 10,000 got tranexamic acid and 10,000 got placebo. And we got a highly statistically significant reduction in all-cause mortality and death due to bleeding. If you gave tranexamic acid soon after bleeding onset, within 3 hours of the injury, it cut death due to bleeding by 1/3. So the military were the first to get interested in this result. They invited me to Washington to talk to some military medical generals and things. And I went to Arlington Cemetery before the presentation, and this was at the time of the Afghanistan war, and this hillside happens to have about 100 graves of soldiers who were killed in Afghanistan, and most of those soldiers would have died from bleeding. And so I photoshopped a 1/3 reduction in death due to bleeding, and it's quite substantial. You know, why wouldn't you want that? And they did want it, and it's gone into military medical protocols. In our trial, we did not find any evidence that tranexamic acid increased the risk of vascular occlusive events, just like the previous trials. In fact, in the CRASH 2 trial, we found a significant reduction in the risk of thrombotic events with tranexamic acid. So this was a statistically significant reduction. I don't know why. It's possible that by preventing bad bleeding, the patient isn't as sick, and being sick is a very strong risk factor for thromboembolic events, because you spend more time in intensive care, more time in bed, and those are important risk factors for thrombotic events. So this is the little girl. I found out that she was still alive, and she was 96 when I met her, and I had the pleasure of presenting her with a plaque on behalf of a certificate on behalf of appreciation on behalf of the CRASH 2 trial collaborators. But she said to me, well, you know, your trauma trial is very interesting, but the one I've always wanted to see the results of is tranexamic acid in postpartum hemorrhage, because that's why I invented it, she told me. And by that time, we were doing another big trial called the Woman trial, another 20,000 patient trial. 10,000 got tranexamic acid, 10,000 got placebo. We got exactly the same result as in the CRASH 2 trial, a 1/3 reduction in death due to bleeding. Really tremendous. It also cut the need for reoperation due to bleeding by about 35%. So really nice result. Now, there's only one thing you've got to be careful about tranexamic with as regards tranexamic acid, and that's you must not give it intrathecally. So because of the Woman trial, after the Woman trial, obstetricians started using tranexamic acid a lot more, especially in low and middle income countries. And there have been occasional administration errors where tranexamic acid is given instead of bupivacaine or whatever they use for spinal injection. And if you give tranexamic acid intrathecally, it's not good. So that's something to avoid. But if you give it appropriately, we haven't found any evidence of any adverse effects. Another recent trial, also published in the New England Medical Journal, and this is what precipitated our sort of initiative to try and increase the use of tranexamic acid in elective surgery. This was a large trial, just over 9,000 patients of tranexamic acid in patients undergoing non-cardiac surgery. Major bleeding, 9% in the tranexamic acid group, 12% in the placebo group, highly statistically significant reduction in major bleeding. Thrombotic events, near enough, 14% in the tranexamic acid group and 14% in the placebo group. Slight difference, but if you round them up, and you can see in this bottom part of this composite picture, those survival curves there, there's hardly any difference between them, and no significant difference. So very strong evidence that tranexamic acid reduces surgical bleeding safely without increasing the risk of vascular occlusive events. So in summary, it reduces surgical bleeding, cuts major surgical bleeding by a quarter. It cuts transfusion by 1/3 to 1/4. And although you can never say really that something doesn't do something, we've got data from over 125,000 patients, and there's no evidence whatsoever of an increased risk of thrombosis with tranexamic acid. So it's all very good news. In fact, tranexamic acid in surgery has been in NICE guidelines since 2015, And so all adults having surgery who are expected to have moderate blood loss should be offered tranexamic acid according to NICE guidelines. But a recent audit by the NHS-BT found that a significant number of patients weren't getting it. So patients who should be getting it were not getting it. So our group was put together to, disseminate the evidence and ask that tranexamic acid use is considered in all patients having all adults having inpatient surgery. The dose we recommend is the dose that was used in that New England Medical Journal. It's called the POISE trial. 1 gram tranexamic acid just prior to skin incision and another gram just after skin closure by slow intravenous injection. And it'll make you a safer surgeon because you're less likely to get major surgical bleeding. You're less likely to expose patients to the risks of blood transfusion. So the risks of blood transfusion. Last week, I was asked to give evidence on tranexamic acid use in surgery at the infected blood inquiry. So, some patients are exposed to blood when there's no need to. They're not getting tranexamic acid, which significantly reduces the need for transfusion, and so they're unnecessarily exposed to blood. So the infected blood inquiry were interested in the evidence about tranexamic acid in surgery. And then, as Neil mentioned, we had this blood shortage crisis. So we are currently in a period of, it's called pre-amber, this reduced availability phase. Last month, it became an amber alert where there was stocks were insufficient for to support elective surgery. I know several people who had their operations postponed due to this crisis, and the crisis it got slightly better because elective surgery was postponed, but it'll come back unless we continuously strive to reduce unnecessary blood use. And I think tranexamic acid is a key part of that. And this is a sort of our group working with the NHS Blood and Transplant, have put together this sort of infographic. We've got infographics orientated towards surgeons. We've got infographics orientated towards patients. If your patient is having inpatient surgery, consider tranexamic acid use. It's good for the patient, it's good for blood stocks, and it'll make you a safer surgeon. So thank you very much for listening.
Well, thank you very much, Ian, for a lovely presentation. Very persuasive. I love the pictures of the little girl who first thought of it. Absolutely fantastic. Ian has done extremely well under a degree of duress because about 15 minutes before we were due to go live, his internet failed. So no stress levels there whatsoever. It didn't show a sign of any difficulty. We are beginning to have some questions come in now, and we'll be asking our colleagues those questions shortly. But those of you out there on the call, please begin to put in some questions, and we'll be collecting them all up and then answering them in due course. So now I'm going to ask Professor Ramani Munasinghe to make some observations about, if the evidence is so compelling, why isn't everybody using it? Ramani.
Thanks very much, Neil, and thanks, Ian, for, as Neil has already said, a terrific presentation under duress. And yeah, a great summary of the evidence of both the clinical effectiveness and the safety of this cheap, easy to administer drug. So we know from the NHS-BT audit that Ian mentioned at the end that our compliance with administering tranexamic acid for patients who may benefit from it is not as good as it should be. So the question is why that is. And I guess we haven't got, to my knowledge, the qualitative research to understand that, but let's think about a few hypotheses. So the first is that the syringe usually is in the hand of the anaesthetist, a person like me, and the decision about whether or not to administer tranexamic acid should be a team event, which is something that is supported by both the surgical and the anaesthesia community. So the anaesthetist can administer it at induction of anaesthesia or just after. But what would be helpful, I think, for the anaesthetist and for the team is for there to be consideration of the administration of tranexamic acid in every patient, as Ian has said, who is having major surgery. Now, the NICE guidelines say that it should be considered for patients over 500 mils of blood loss, where over 500 mils of blood loss is a risk. But to ask the question of oneself is the key thing. So in every patient having surgery, ask the question in the same way that we ask the question about a whole bunch of other things that may or may not. We ask about whether the patient has been grouped and saved, if there's even a small risk of significant blood loss. So why not do the same with tranexamic acid? It doesn't mean that you have to administer it, but if you ask the question, then you increase the likelihood that it will be administered in the right setting, in the right context. So there's been discussion about how this can be incorporated into the WHO Safe Surgery checklist. And I think is a straightforward thing to do as part of the team brief in the morning when going through the list of patients. One of the things that can be discussed by the team is whether or not, or what the blood management strategy should be. And of those, tranexamic acid should be something that is considered in all the patients. Then when it comes down to the actual administration of it in theatres, prescription of it in the drug chart, depending on how your operating theatres run, also, again, a useful thing to consider. So if it is a case where administering tranexamic acid is unlikely to be controversial, then why not actually write it up as part of the pre-op prescription in the same way that we would write up prophylactic antibiotics in the same context? So I think having hospital level guidelines is helpful. We've got NICE guidelines, but this is about the behavioural nudges. It's about making sure that everybody in the team considers it to be part of their duty to ensure that it's going to happen. So that rests with the anaesthetist, it rests with the surgical team, it rests with the scrub nurse to give the nudge at the team brief and the time out. There are lots of opportunities to provide the nudge that might lead to the prescription and the administration of tranexamic acid, both at the beginning of surgery and at the end, in the way that Ian has described. So it would be great to get to a position where instead of asking, have we considered it, we're asking, why haven't we considered it in the cases that we don't consider it? That doesn't, again, mean that you have to give it for every case, but it should be part of the conversation that you have about every patient having inpatient surgery. If you can see that subtle difference, I think that would be a way forward to think about the behavioural changes that are required. Thank you, Neil.
Thank you, Romany, very much. So we've got some questions coming in. First question, Ian, is there any evidence, we're asked, that tranexamic acid is effective all around the moment of a caesarean section? Or have you only got evidence related particularly to vaginal delivery? Is there anything particularly on caesarean section?
Well, that's an interesting question. So the woman trial looked at tranexamic acid for the treatment of postpartum hemorrhage. And after that, we got this 1/3 reduction in death due to bleeding with tranexamic acid, but still there was significant numbers of women still exsanguinate, even if they get tranexamic acid. So it cuts the risk by 1/3, but there's still a risk. So we've launched another big trial called the Woman 2 trial of tranexamic acid for the prevention of PPH. This trial has recruited 10,000 patients, and we expect to get a result in the middle of next year. There's been a couple of randomized trials of tranexamic acid for the prevention of bleeding in caesarean section. They haven't been as big as I would have liked them to be, in a couple of thousand patients. There was less bleeding with tranexamic acid, but as the questioner recognized, the most important question is about thromboembolic events, because pregnancy is prothrombotic state. So I think we need more evidence on that topic before tranexamic acid is routinely offered to women with cesarean section for the prevention of bleeding. But it's that's an area where there's a really interesting question that needs to be answered with more data.
Good. Ramani, any comments on that? Perhaps not, as you're not an expert in the obs and gynae field, if you don't mind me putting it like that. Somebody's asked why Ramani give it as an infusion rather than a bolus. What's going on there?
No, I think the evidence is to give it as a bolus at the beginning and a bolus at the end of surgery. That rather than as an infusion, it's straightforward to give. There's no evidence that I'm aware of any benefit over any benefit of giving it as an infusion. So just a bolus at the beginning and end.
Okay, and there are a couple of questions from oral surgeons. Is there a topical application? You can't. One of the questions says get it as a mouthwash. You'd still give it systemically, would you? Systemically in that situation? I don't know. Do either of you have any information about oral surgery?
I do have the information about topical use. So there's been some systematic reviews of randomized trials of topical tranexamic acid use, and it does reduce bleeding. Obviously, you've got the challenge is making sure that you get to the bleeding area. I would say it's not superior to systemic use. So if it was oral surgery, I would administer an intravenous dose of tranexamic acid.
Okay.
There is evidence that tranexamic acid mouthwashes reduce dental bleeding, for example.
Yeah, I think that was one of the questions asked about dental surgery particularly. Okay. Can I ask, what about increasingly surgery becomes bloodless as we use not just ordinary scalpels and not even flick knives, but various kinds of energy devices? I'm pulling your leg in, but would you say that everybody in a surgical department where blood loss was expected to be absolutely minimal should still have tranexamic acid, or should it be as part of the checklist, this patient's going to lose over 200 or 300 mils, so maybe we should give it on this occasion? What do you reckon?
Probably one for Ramani, this one. I'll let her go first.
The evidence, as I understand it, Ian is the expert on the evidence base, but the evidence, as I understand it, is in patients who are at higher risk of bleeding. So while I think that it's reassuring that the safety profile is there, the evidence is in the patients who are at a risk of at least moderate bleeding. But I'll say two things on this. So the first is to have that conversation. Whatever the case, the conversation about whether or not tranexamic acid or indeed other blood management strategies are required should happen as part of the timeout, as part of the WHO checklist, and as part of the team brief in the morning. So that's one thing. And then the second is that we are, and this answers another question I think that's come in. I am approaching NICE about whether or not they would consider updating the guidelines that they previously published. So there's generic guidelines, and then there's guidelines specific to joint replacement surgery, and whether there's an argument to update those guidelines because some significant evidence has come in since they were originally published. And so it will be interesting to see if we are able to get those guidelines updated, what they say as well. But for now, I think the key thing is to have the conversation, because what's clear from the NHSBT audit is that we're not achieving what we need to in the patients who would benefit. So in order to make this part of routine care, it would be useful to discuss it in every patient.
Very good. Ian, then can we come to you? The use of tranexamic acid and anticoagulants, post-operative prophylactic anticoagulation. What about tranexamic acid and enoxaparin post-operatively? What's the evidence around using them both?
There's no problem at all from using them both. I mean, this is, I think this is a very interesting question, because there's a sort of intuitive reaction. Well, I'm using this to stop bleeding, and I'm using this to stop thrombosis. Is that a problem? Well, it's not a problem. You know, they're both risks that the patient faces, and so actually we need to prevent both. And we can, you know, we can prevent bad bleeding with tranexamic acid, and we can prevent post-operative thrombosis in you know, with anticoagulants. So they're not mutually exclusive at all, and we mustn't think that one is doing the opposite to the other.
Okay, that's great. There's a question, I'm not quite sure whether, Ramani, you can answer this one, around pediatric surgery and pediatric spinal surgery. Use in children particularly, any thoughts or comments?
Well, what I can say, because after the CRASH 2 trial, where we showed that tranexamic acid was an effective treatment for traumatic bleeding, the Royal College of Pediatrics and Child Health considered the evidence, and they made a recommendation about tranexamic acid use in children. And because there were no big trauma trials in children, because thankfully major trauma is relatively rare in children, although it, you know, is still a significant cause of death, they had to rely on other evidence. And the evidence they relied on is actually children having spinal surgery, because it's very, you know, there's a lot of bleeding. And tranexamic acid definitely reduces surgical bleeding in that setting. So, you know, scoliosis surgery, various, you know, spinal surgeries that are very, lead to a lot of bleeding, tranexamic acid is safe and effective in that setting.
Good, that's very helpful. You mentioned the CRASH trial. Sometimes we see patients who have, say, a major liver injury and they lose quite a lot of blood, and the transfusion department begins to worry if they're going to run out. Indeed. So you've suggested a bolus at the beginning, and if you're in a situation where there has been massive blood loss, is it still effective then, or is it a bit of a waste of time?
Well, what we find is that what the evidence shows is that tranexamic acid reduces death due to bleeding by about 1/3, regardless of your baseline risk. So if you get a trauma patient that's been run over by a train, both lower limbs amputated, major hemorrhage, you know, exsanguinating hemorrhage, that patient might have a 30% risk of dying from bleeding. Tranexamic acid reduces that from 30% to 20%. Similarly, at the lower end of the risk, if you've, you know, an older woman fallen downstairs, she might have a 3% risk of death due to bleeding. Well, tranexamic acid also reduces that by 1/3. So it needs to be given in the major liver laceration patient. It's not enough. It doesn't replace the surgeon. It helps the surgeon, I hope, but you know, everything else, you know, you just basically, you know, give it and then forget about it, and then do all the other things that you need to do. So, but we've got overwhelming evidence that it helps in those situations.
And you mentioned the military and Afghanistan and other conflicts. Is it now routinely used by the military?
Yes, it went into combat care protocols first by the British military in 2010, and the US military in 2011. They were a bit skeptical. They'd got their fingers burnt with a drug called activated factor 7, Novo 7. So they were a bit cautious. But now, yes, it's widely accepted by the military. In fact, I'm working with the military in the UK on the development of a tranexamic acid auto-injector that can be used on the battlefield, because what we've found is intramuscular tranexamic acid is rapidly absorbed. And so in the future, I think, you know, tranexamic acid auto-injectors for pre-hospital care or battlefield injury will be available.
Yeah, interesting. Romani, we talked about cultural change and the whole problem of persuading the late adopters, shall we say. Have you got any other thoughts on ways in which we can do that better?
Well, I think, the usual things around education, audit, those sorts of things will help. I think that certainly at NHS England, we want to consider whether or not a sequin would be something that would be of value. I'm uncertain that that will be possible to implement one for the next financial year, but I think it might be possible to at least consider it for the one following that. So there are those sorts of incentives, but it would be nice to think that we could get a bit further than where we're at the moment without the financial incentive necessarily. So I think local guidelines that are backed up by the evidence, particularly as the evidence has now been amplified this year, and the blood shortage that Ian talked about earlier has really raised the profile of this issue in a way that it might not have otherwise been possible to do. So education, self-audit, and in the same way as normal with quality improvement, you don't have to audit every single case going through theatres, but you can take a small sample and continuously look at it and see what your rates of compliance are. And then, as I say, introduction into the checks and balances, whether that's the prescribing habits of the member of the team that's responsible for the routine prescriptions around the time of surgery, whether that's antibiotics, thromboprophylaxis, and whatever else, should tranexamic acid for certain cases, certain procedures, be part of that portfolio of things that are routinely written up. Second thing is consideration at the WHO checklist stage between the anaesthesia and the surgical team, and having that combined approach. But the education thing, I mean, it's interesting seeing some of the questions coming in. There's a question about colorectal cancer surgery and whether in that particular group of patients there's a risk of increased thrombosis. As I understand it, there are no subgroup analyses that indicate any risk in any increased risk in any particular subgroup of patients. So this is considered to be an effective and safe intervention in all of the settings that it's been tested in, which will include a significant number of patients with cancer and having cancer surgery. So that shouldn't be an exception for considering its use in the surgery that's being undertaken.
So we don't know whether there are any sort of frequent offenders or departments who are sort of outliers or anything yet, but maybe we'll get to the point where we can have that information to be able to educate and persuade and nudge and all the rest of it. So yeah, you mentioned some further questions. When we began to mention, Ian, this to patient safety teams in NHS England, they still had some concerns over its use, and maybe they were concerned about increased VT risk in cancer, and maybe the whole business of sort of medical legal implications in the medium to long term. Where are you in that space?
I think if you don't know the evidence, it's very reasonable to think a drug that reduces bleeding might increase the risk of vascular occlusive events, thrombotic events, unwanted thrombosis, DVT, pulmonary embolism, heart attack, strokes. So it's a very understandable hypothesis. The trouble is it's been refuted by lots of evidence now. So, as I mentioned, there are over 125,000 patients in randomized trials of tranexamic acid in surgical and traumatic bleeding, and they don't find it to be true. In fact, the larger quality trials find less bleeding, slightly less bleeding in the patients who get less thrombosis in the patients who get tranexamic acid. So there comes a time when we have to let go of our intuition and say, right, okay, this has been refuted by the evidence now. Now I've got to, despite my intuition, I've got to let the evidence override it. And, it's the best thing I can do for my patient, because I believe it will likely reduce surgical mortality. If we did this across the board, I think major hemorrhage contributes to surgical mortality. I think that's supported by the literature, and tranexamic acid reduces major hemorrhage. So I think we can look forward to less surgical deaths if we're, all patients are considered, that should get it.
Probably an evidence-free zone here, a question which you might have seen around breast surgery and seromas in addition to bleeding risk. Again, this is a collection of fluid in the operative space, but I think it's pretty difficult to get that information to see whether tranexamic acid would work. That's maybe a trial for the breast surgeons to do in the future, I guess. And
yeah, I don't know the answer to that one.
a question about lower GI bleeding. If the patient isn't fit for surgery, is tranexamic acid worth giving in that situation? Again, probably not a great deal of evidence, but maybe it makes sense.
Well, we've also done a trial of tranexamic acid in gastrointestinal hemorrhage, and this is the only setting where we did not find a significant reduction in death due to bleeding. We did a big trial called the HALT-IT trial it was mainly patients with esophageal bleeding due to cirrhosis. So, and we didn't get any benefit and we didn't get any harm, but I wouldn't recommend it in that setting. It might be that the pathophysiology of bleeding in surgery, trauma, and postpartum hemorrhage, where there's kind of rupture of blood vessels, is different from these esophageal varices. You've got a varix sitting quietly in your esophagus that just pops, and then glug, 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 blood fills up the stomach. The other thing about gastrointestinal hemorrhage, you never really know when it started. And the evidence, the one thing we do know about tranexamic acid, it has to be given soon after bleeding onsets, preferably in surgery before. But with gastrointestinal bleeding, you don't know how long it's been going on when the patient fronts up, because when they vomit blood, it's not the same time as they started bleeding.
I mean, along similar lines, there's a question you might have just seen around fractured neck of femur. You don't always know exactly when it happened. Is it worth giving tranexamic acid in those patients, or would you use it selectively? What would be the pros and cons?
Well, in our trials, because we're doing a trial of tranexamic acid in older adults with mild traumatic brain injury, we recommend that if you don't know the time of injury, it's probably best not to administer. Most cases you do know the time of injury, but sometimes you get patients who've been on the floor for 12 hours or so, and then it's probably not helpful to give tranexamic acid in that setting.
And so there's a question about kidney transplant patients and small vessels transplant patients included in the study group.
I think so. I think any surgery. I mean, the POISE trial had this subgroup analysis at the back of it. It was in the supplementary appendix, and they looked at each individual type of surgery, and we've done this with our meta-analyses, and we haven't found any. It's effective regardless of the type of surgery. It's about surgical bleeding and where the patient is bleeding from, and why. It seems to be less important. Well,
question
where
here about,
important.
Yeah. Sorry. Question here about patients with a procoagulant disorder or history of recurrent thromboembolic episodes. What do we know about that patient?
That's not a contraindication. I think if a patient had a current active thrombosis, I wouldn't give it. So, if a patient had at the time of the operation was known to have a DVT or a PE or some, obvious thrombotic event, but a history of thrombotic event is not a contraindication. And that's important because quite a lot of patients do have a history of some sort of thrombotic, thromboembolic event, heart attack or something like that. And in a way, the POISE trial, this one that appeared in the New England Medical Journal recently, they specifically looked at patients who are high risk for both bleeding and thrombosis. And so they found evidence of benefit and no evidence of harm in that patient group. So a history of thromboembolic events is not a contraindication.
Great, that's very, very helpful. There aren't any more questions on the screen. I was just going to ask Ramani if she has any concluding remarks just before any last questions come in.
Thanks, Neil, and thanks, Ian. I think the amber blood shortage crisis has now, as Ian's already said, we've gone back to a pre-amber stage. That's a huge relief, but it's an opportunity to reflect and think about how we should be improving the quality of care for patients, because it's not just about protecting blood supply at time of shortage. We should be looking to protect blood supply at all times, because it is an important commodity. And furthermore, we should be looking to avoid transfusion in as many patients as we can, because transfusion is not without harm, as Ian has already demonstrated. And anemia is not without harm in patients who have postoperative anemia. So the idea of administering something which is safe and effective in the right context, it seems unarguable, and it's not even expensive. So I think there is little doubt that this is something that we should be doing better at as a community. And I think that the support of the professional bodies, particularly in the last few weeks around the blood management crisis, around the blood shortage crisis, has been incredibly helpful. So it's now, as I've said before, for local teams to think about local audit and improvement, reassurance that you are administering it in the right context, and thinking about the checks and balances locally that you can apply in order to improve compliance, whether that's adjusting your checklist, whether that's thinking about the prescribing habits of the surgical teams, particularly for particular cases, and certainly discussion at team briefs and timeouts. Thank you.
That's great. There were a couple more questions coming in. Ian, rubbery clots and difficulties in patients with hematuria. Apparently, a urologist has written to you about hematuria particularly. Any comments on that?
Yes. So I'm aware that there's quite a few case studies where patients have been given long courses of tranexamic acid for hematuria, and it's not indicated for that. So sometimes, although it's difficult to get a cause-effect relationship because these are case reports, patients who might have, for some reason be bleeding into their, ureters, if long courses of tranexamic acid have been associated with sort of, I think the questioner said, rubbery clots inside the calyx of the kidney, or so it's not a treatment for hematuria. It's a treatment for surgical. It's not a treatment. It prevents surgical bleeding.
Bleeding hemorrhoids, just while we're down there in that zone, any evidence about those? I'm not being serious, actually. Ramani, coronary stents, is that a contraindication to patients having, if you're requiring major surgery, you've recently had coronary stents, do you reckon that's a contraindication to use of tranexamic acid?
So I'm not sure, if I'm perfectly honest. I mean, I think if the patient's having had recent coronary stents and is having major surgery, unless it's emergency, I think you'd have to question the benefits of going ahead with surgery at that time. I think there are bigger considerations really around the management of that particular patient. But I don't know, Ian, whether there's been any in patients who are on, for example, dual antiplatelet therapy such as clopidogrel and aspirin after, drug insertion. We would try and avoid.
Look at the POISE trial, because they had lots of patients in that trial who are at very high risk. What we've seen, which I think is important to bear in mind, is that bleeding is a strong risk factor for thrombosis. So having a bad bleed puts you at higher risk of having a thrombotic event. So preventing bleeding is very important in patients who are at high risk of thrombotic events. So they probably go in the same direction and not against each other.
So, I mean, there are one or two other questions which are similar to the ones we've already answered, so we won't go through that again. And the National Emergency Laparotomy audit recommendations might include this in the future. I was going to let you, Ian, have the last few words before we wrap up, if that's okay, please.
Well, that's good, because I just want to thank you, Neil, and Ramani as well, for your leadership on this issue. So, you know, I'm just a random clinical trialist, and I don't think I would have managed to impact it on anything except the evidence base. But you two have taken on this as an issue, and so I think your support for this issue, I think, has been really important, and I'm very grateful to you both.
Okay, so we've done the questions extremely well, and I'd like to thank everybody for watching. If any of your friends would like to hear about the issue, this webinar will be available as a recording in due course. I want to say a big thank you to Ian and to Ramani again for a really, really great seminar, webinar. Lots of interesting questions, lots of nuanced questions with the subtleties around the edges. I think we've given Tranexamic acid a very good airing, and if you want my word on it, the evidence is so compelling we should be using it as a default and only not use it if there's a very, very good reason not to. So we're going to leave it there and say thank you very much, everybody, for listening, and thank you again for our panelists for a super webinar. Thank you.
Thank you.
Thank you.